spiritual self-assessment by patients, and spiritual care engagement by interprofessionals. In 2009, it was recommended that formal spiritual care screening and assessment be provided by all American interdisciplinary palliative care teams. The model is arguably generalizable. In 2013-14, using a continuous quality improvement process, Bond developed a tool that reports patient behaviors, relationships, thinking, attitudes, and reactions, profiling their religious and spiritual reality in practical terms. Intended is the resourcing of every interdisciplinary team member's engagement with their patients on these matters. The Spiritual Care Engagement Tool, or SCET, was and remains a novel patient profiling tool. As a useful aside, all Niagara Health staff can access the SCET through SourceNet. Just go to Spiritual Care's SourceNet page, scroll down to the bottom, and click to open up the SCET, which looks like this. From Spiritual Care's SourceNet page and also from Niagara Health's electronic forms repository, you can also open up a corresponding chart form to record a patient's profile. Note that there are training modules for any interprofessional staff member interested in understanding the SCET more fully. A 2015 quantitative research study, the SCET study, found that only rarely will interprofessional staff members actually administer this tool. The next phase of the work reasoned that the desired information could be provided directly by patients. Through multiple quality improvement cycles in 2016, Bond and Brown developed a well-functioning spiritual self-assessment tool, the SSAT. The SSAT can be found in Niagara Health's electronic forms repository. It looks like this. Again, it can be accessed via Spiritual Care's SourceNet page, along with a letter that introduces it to patients, and a user guide for our interprofessional staff. In November 2016, the SSAT was integrated into patient care on a test unit, Welland's 6th floor medical. Next came our study of the tool in use. Consenting near-to-discharge patients completed a questionnaire. Simultaneously, our research assistants administered the questionnaire on GNG's Medical Unit C for control. The dataset was opened at midpoint, whereby it was found that patients completing the SSAT were simply too few to answer the primary research question, or validate the SSAT. Be that as it may, the data from 100 completed patient questionnaires is instructive, indeed compelling. Between 1/5 and 1/3 stated their care team did not understand their views on life, nor their beliefs about sickness and health, nor how I view my illness. Of these, 90% stated it would have been helpful for their care team to possess this understanding. 26% stated their view of life and/or their life circumstances caused them distress during their hospitalization. Of these, 35% disagreed that their distress got to be expressed and addressed as part of their care. 21% stated financial stress played a role in their sickness, including impacts on coping strategies. Of these, 43% disagreed that the care team was aware of their financial distress, and 48% disagreed their care team was useful in helping overcome financial barriers to health. 37% stated it would have helped if their care team understood more about their family and friends, their community. 17% stated disagreement that their care team knew about the ways they take care of themselves and support their well-being. Of these, 41% stated they wished their care team understood their self-care and coping strategies. The most manifest result of the clinical trial is that providing the SSAT to newly admitted patients and expecting them to complete the assessment independently is unsuccessful. Secondarily, though, it is verified that there is a significant fraction of patients dissatisfied because they want and need this information to be in the hands of their care team. Systematic means of doing so remain elusive. One effort underway is to encourage SSAT completion ever before hospitalization. Alongside this, interprofessional team members are urged to pick up on the use of the spiritual care engagement tool. It is there, available for everyone's use. This research is published in the Journal of Pastoral Care and Counseling. We gratefully acknowledge financial support received for our research assistance work.
Hello, my name is Karen Tapley, and I, along with my colleagues, Dr. Sheila O'Keefe McCarthy, Melissa Knoops, and Alicia Salenzi, welcome you to this poster presentation titled Spyglasses and Simulation Change the Practice of Reflection to Make it Patient-Centered. Reflecting on one's practice is essential for healthcare workers to enhance, change, or improve the care they provide. The common practice for reflection is self or peer reflection, which focuses on the caregiver, not the patient. A new methodology was created using spyglasses combined with simulation in order to enable reflective practice from the patient's perspective. This presentation is a compilation of 3 different studies using this methodology. The studies consisted of 1 case study and 2 phenomenological studies. The first consisted of 21 senior nursing students caring for a nonverbal ventilated patient. The second study included 6 personal support workers who were tasked to care for a palliative care patient. And third included 8 senior nursing students who cared for a pediatric patient in pain. In all 3 studies, the patients wore spyglasses that captured audio and video. After caring for the patient, the participants watched the video and were debriefed using the reflective practice from the patient's perspective tool. 4 themes were consistent across all of the studies. The first theme was that participants critiqued the care they provided and their role. This theme focused on the ways that participants appraised their actions during the simulations, good or bad. Multiple participants spoke on how reflecting from the patient's perspective allowed them to appraise themselves differently. This theme was evident in all 3 studies, but was really solidified in the 3rd study, which named this theme, I could have, I should have, I would have, I will. As part of appraising their performances, the participants spoke to multiple and varied things they would like to change, commenting on what they believe they should have done or would do differently in the future. For some, it was validating to critique themselves as they found positives in the care they provided. One participant shared, I actually looked like I knew what I was doing, and a lot of times in clinical, you feel very lost. The critique of care and self was pivotal for the participants to either validate or their practice or identify aspects that they would change. The second theme was that the environment and the equipment impacted the care provided. This theme highlighted the emotional responses participants had about the equipment and the environment. Participants expressed feeling overwhelmed, unsure, and uncomfortable. Another aspect related to the environment was the concept of proximity. Participants often commented that they felt intimidating, too close, hovering over, and invading the patient's personal space. This gave the participants pause, and they reflected on the impact of the environment and the equipment and their proximity to the patient related to the care they were providing. The third theme was that communication can be imbalanced between the patient and the caregiver. Working with a patient who was nonverbal and on a ventilator proved to be a challenge for the majority of participants, as they had not yet cared for a nonverbal patient. However, this resulted in insightful and meaningful reflections about their communication styles. Several participants commented on the fact that communication seems one-sided or imbalanced. Participant 4 said, I don't think I really gave the patient much of an opportunity to communicate. I think in this situation, the communication was really so imbalanced. You know, all in the nurse's power, like you have so much power. I think the patient could have been trying to communicate, but I wasn't giving them the opportunity. In the pediatric simulation, study participants spoke about the need to change the specific words and semantics that they used in their conversations with the parent and the patient. They spoke about age-appropriate language and reflected having difficulty explaining care so that it was appropriate for both the parent and the child. The fourth theme was realizing the patient's experience was different from their experience. Participants highlighted again and again the powerful impact using this method to reflect had on them. They commented on what it must have been like for the patient and what the patient must have been seeing, hearing, feeling, and experiencing. Additionally, they commented on how the care they provided would have been perceived. This is a powerful and insightful method for reflection that can improve patient care. In conclusion, patient-focused reflection impacts the learner's ability to critically think and ultimately improves patient experiences. Allowing the patient to become the center of all healthcare practices and interactions serves to humanize the patient's experience.
Hello, everyone. Thank you for the opportunity to present my Master of Applied Gerontology research at this conference. My research is titled, What Matters to Older Patients? A Mixed Method Study of Older Adults' Experiences at the Niagara Health Geriatric Assessment Program. This research came out of the Outpatient Geriatric Assessment Program's desire to understand the lived experience of older patients this program serves. Notably, older adults comprise over 50% of all of the acute care patients seen at Niagara Health, which is only expected to increase as the population ages. This changing landscape highlights the absolute need for sustainable, patient-centered geriatric services within the Niagara region. The goal of this project was to understand the lived experience of older adults currently attending the program, to identify novel ways to improve the experience for current and future patients, and identify areas of improvement that may improve other outcomes within the program. We achieved our goal by completing semi-structured interviews with 38 of the patients and caregivers who attended the program between April and August of 2021. We then categorized the responses into themes, and from this feedback, 6 key recommendations were produced. These recommendations, which you can see in the middle of the poster, include increased partnership with community services, the addition of a patient navigator to liaison between community services and patients, a referral audit to identify the most frequent patient population referred, creation of a large print handout with senior-friendly font about what to expect at a GAP appointment, creation of a standardized fillable summary sheet of what was discussed at the appointment for patients to take home, and offering syndrome-specific pamphlets. These standardized fillable sheets and syndrome-specific pamphlets would be created based on the results of the referral audit of what patient population is most frequently referred. After thematic analysis of the responses patients and caregivers expressed, 2 areas of improvement and 3 areas done well were identified. Patients and caregivers expressed that they simply wanted more information, as this was often their first encounter with geriatric medicine. They also expressed that they would like reduced wait times, as many individuals had to wait a long stretch of time for their appointment simply due to the nature of the COVID-19 pandemic. 3 areas done well include the compassion patients and caregivers felt from the GAP staff, satisfaction with the quality of the referral sent, and an overall positive experience despite an unfamiliarity with geriatric clinics. It is my hope that these recommendations will be useful in the future program planning as the need for specialized geriatric services continues to grow within the Niagara region. I would like to offer the sincerest thank you to the GAP team for their support and mentorship throughout this project, as well as to the patients and families who participated and shared their stories with me. Thank you very much for listening, and I look forward to discussing this research further with you. Enjoy the rest of the conference and have a great day.
Hi, I'm Larissa.
And I'm Monsi.
And our project is called Patient Relations, using upstream approaches to pursue compassionate and patient-centered care at Niagara Health. Now, just to provide some background or context as to what patient relations actually is and what it does, in 2010, the Ontario government created the Excellent Care for All Act, which required all hospitals and healthcare organizations to have a patient relations department. Recently, Niagara Health had been noticing an uptick in patient complaints, and while they were often able to course correct to address the immediate issue at hand, their model was not necessarily preventive or upstream.
As a result, the aim of this project was to help Niagara Health create a patient relations model that facilitates prevention rather than relying on a patient complaints process. We decided that the best way to accomplish this is to establish a framework which shifts the organizational culture to one which facilitates compassionate and patient-centered care. To begin building the framework, we reviewed the following sources. First, peer-reviewed journal articles on patient-centered care and other related concepts. Next, we also reviewed the best practices in patient relations in the top 10 healthcare organizations internationally. Additionally, we reviewed patient complaint data directly from Niagara Health, and lastly, we reviewed the Niagara Health Patient and Family Declaration of Values as well.
So after reviewing those sources, we accumulated 5 main themes. The first one was communication, or communicating information clearly and in a way that is tailored to the patient, which is often demonstrated by behaviors such as active listening and asking open-ended questions. The next theme was empathy, compassion, and respect, which we defined as understanding each patient's personal experience and ensuring patients feel safe enough to share their concerns and health issues. Another important theme was shared decision-making, which involves incorporating patient and family perspectives in the treatment plan and involving families in healthcare decisions. The next important theme was teamwork, which was defined as communication and collaboration between members of the care team, as well as with patients and families. Another important aspect of teamwork involved creating a safe environment where each team member's ideas are valued and encouraged. Finally, the next important theme was accountability and responsibility, or ensuring that the patient's best interests are a priority by taking the opportunity to follow up on patient concerns in order to learn from them and enact meaningful change.
After defining these values, we've also distributed a short survey to Niagara Health staff seeking their feedback on this list of values. Once we have this information, we will revise the list accordingly and continue to build this framework. While the project is still in an early stage, we do hope to pioneer innovation that can be applied in settings outside of Niagara Health and perhaps provincially. Thank you for listening.
Hello, and thank you again for taking some time to learn more about my team's research. So my name is Noah James. You may have seen me before at the poster presentation, and I'm back with the second component of my research here, and that is supporting the ECP program, or Essential Care Partner Program, at Niagara Health. So this kind of ties into the scoping review, so if you haven't checked that out yet, go ahead and check out that poster as well. So building off of that evidence, right? So again, we're in the context of the COVID pandemic. We know that there were sweeping hospital visitor restrictions introduced across Niagara Health, across all hospital organizations around the world. These were sweeping and immediate, right, to try and mitigate the transmission, the spread of COVID-19 within the hospital setting from the community, and so that's why they were introduced. However, they were introduced quite broadly, sweeping, right, and immediate. And so there wasn't as much time for consultation with key stakeholders to find the best balance of how to implement these restrictions. And so there was a lot of unintended consequences that was a result. And so based on that, we did a scope review, found some evidence to support changes to the ECP program. And then so that really supported the patient experience side of things. Now, what's really important in a holistic model and a patient partner model, right, is that there's feedback from all sides. And so this is what led us to do a staff survey to gauge staff opinions, awareness, attitudes towards, and if they had suggestions for the current Essential Care Partner Program prior to expanding a similar program in ambulatory care. So the objective of this research in particular was to review the current ECP program and optimize functioning and sustainability, doing this through gaining insight into staff experiences and opinions, and understanding how aware the staff are, their engagement with it, and of course, if they have suggestions for improvement, as they interact with the program daily, and so they're probably going to have the best ideas. So we distributed an electronic survey across the Niagara Health organization, and we were thankful to have over 400 responses back. About 375 of those were complete responses, and so thank you to everyone who participated, or thank you to everyone who considered to participate. We understand it took a little bit of time, and so some may not have been able to, but again, we appreciate those who participated. The survey was built up of a few components. So the first piece was a yes or no sort of dichotomous section, and this was to gauge the awareness of the program. Did they know that it existed? Have they been a part of it? Have they worked there as a patient or interacted as a staff member with the program? And so that was our first piece. And if they were aware of the program, had been involved with it, we wanted to learn more about their experience. And so this led us to the second component of the survey that had more Likert scale type questions, as well as some open-ended responses that allowed us to dig a bit deeper into the suggestions to move the program forward, but also to learn what was working well. Out of those who responded, we had the majority aware of the program, so that was great, knowing that the organization is aware of what's going on. Again, out of those who were aware, a majority had been a part of the program or knew how to start the process, which was really fantastic. And then out of all of those, we got down to about a quarter, or just shy of a third, of those who responded with complete responses were able to move on to the Likert scale and open-ended responses as they worked directly with the program. As we move on, you can see in the graphs on the screen here, as well as in the tables, this kind of summarizes the general trends that we were seeing. So that is, on average, right, the majority of respondents said that the criteria was pretty clear and simple to identify and recruit an ECP. The process to identify and recruit for staff was simple and easy to navigate. That was felt pretty well, although there was some suggestions for improvement in streamlining that. But the most resounding consensus was around that the ECP, so the essential care partner, is valued by staff, physicians as a way in which to improve patient and family care experience at Niagara Health. So that was really great to know that they are a really valued part of the care team and adding value not just for the patient, but also for the staff as well. So as we dug a bit deeper, we did a thematic analysis with 2 reviewers of the open-ended question and responses, and this was really great, gave us a lot of insight and feedback. What we learned is that there's a lot going well. They're seeing a lot of improvements have been made, and there's a lot of more improvements coming down the pipeline, which is fantastic. Some suggestions were really great, one of which was something called Ecp Champions. So this would be having sort of a mentorship type position for those who have been ECPs in the past to help orient and support new essential care partners as they become involved in their loved one or family members or compassionate persons care as well. And so the survey was really informative, and again, we'd like to thank all the staff and thank you again for taking the time to read our research. Hello, and thank you for taking the time to learn more about my team's research. My name is Noah James, and I'm in the final semester of my undergraduate degree in medical sciences. Our poster, titled The Impact of COVID-19 Hospital Visitor Restrictions on Patients, Caregivers, and Staff, takes a look at how the pandemic shaped the hospital's response, that is to visitors, and what impacts and effects that had, either intentional, unintentional, or unpredictable. So to begin, we conducted a scoping review in response to, of course, the very sweeping and immediate restrictions that were put into place by hospitals, much similar to those in place at Niagara Health. And we wanted to look at and investigate what literature is out there describing these perhaps unintended consequences or unintended effects that we're seeing later on now that these restrictions have been in place for several months. So what was the aim of our research? We wanted to support the quality and patient safety staff at Niagara Health to ensure that their pandemic response was evidence-informed. And so part of that was investigating the literature here to see how their visitor restrictions have impacted their staff, caregivers, and patients. To do our scoping review, we decided to comb through PubMed, Embase, MCare, Medline, CINAHL, and Medrix. That's a preprint server. And so we electronically searched these for both peer-reviewed and preprint literature. We decided to include preprint as the rapidly evolving nature of COVID research is that there's a lot coming down the pipeline. There's a lot that is put into preprint then published right away, and so we wanted to get the best pictures possible, and it was actually quite helpful in finding some relevant citations. We decided to use criteria that included September 2019 or later. We really wanted to capture this pandemic in particular. Although there was some hits when we initially did some test searches earlier on from SARS and other historical events, we really wanted to keep the context centered around COVID and the pandemic that we're experiencing now. The citations included, again, had to have at least one keyword, take place in a hospital setting, and discuss an impact, outcome, or evaluation. And so we decided to exclude those articles that really focused only on the infection prevention piece and only looked at those metrics, as we wanted to dig a bit deeper, understand what is going on, how are the patients feeling, how is this affecting them, their caregivers, and the staff as well. How are they feeling, how is it affecting their jobs, and so on. So we found potentially 2,000 roughly relevant citations. That narrowed down to about 48. So quite a few that we excluded. Most, again, were based on date. The date was kind of decided after our initial search, but was thoroughly applied to all relevant citations. Out of that, most of the literature that we found came out of the United States, a couple other Commonwealth countries as well, that being of Australia as well. It was pretty diverse across a number of units. However, some programs were more represented than others, such as pediatric with 10 articles, ICU with 9, obstetrics with 5, palliative care 5. The remaining programs had just a couple to each name. I think that it was included, the ED, oncology, the general hospital, and a few other programs as well. When it came to looking through these articles, what did we find? What did we learn? Well, we came across and sort of devised 4 major themes. The first being leveraging the use of technology. This was both beneficial and detrimental on patient experience, patient care, and also challenged and yet aided in some respects the staff workflow and workload. And so it's a bit of a tricky thing we're still trying to navigate, but it's important to remember that there was both positive and negative effects from this. And that sort of positive and negative trend kind of carries through the other themes. So the impact on vulnerable populations. In this regard, some articles identified that they were really hard hit, right? They were really struggled as, maybe their primary caregiver, someone who they relied on for communication, was unable to be with them. And so that, again, impacted the experience. Quality of care considerations, right? So oftentimes caregivers provide services and assist with things such as meal times, hygiene and stuff that might not be expected, but often occurs. And so that added quite a bit of strain on the staff when they were not present. And of course, mental health concerns. And this is seen across programs and everywhere from the ICU to obstetrics to the emergency department and across the hospital. So these were really wide sweeping concerns. And so based on these findings, this has helped to inform some of the improvements that are going forward to work on the current Niagara Health Essential Care Partner Program and a potentially new program coming out similar in ambulatory care. Thank you.
Hi everybody, my project is on assessing perceptions of primary care quality in people experiencing homelessness during the COVID-19 pandemic, and I've listed everybody working on the project underneath that. All right, I'm going to zoom in to make it a little more viewable. All right, we can start with background information. So approximately 35,000 Canadians experience homelessness on a given night, and roughly 625 of these people are coming from the Niagara region. Generally, this population has poor health outcomes in mental health conditions and chronic conditions like diabetes and hypertension, and this is due to a variety of factors. Particularly, these people do not have access to a family physician typically. They also experience a variety of logistical factors, including transportation, and emotional factors, including stigma and a lack of trust in physicians. As a result, we wanted to conduct a study to help understand patient perspectives about the care they receive in clinics when they're in shelters. And in Niagara in particular, shelter health networks are run through the REACH program, the Regional Essential Access to Connected Health. And we're working with this program to see if we can gather results to guide future policy reforms to help improve the clinics, as well as to work on future quality improvement projects. A secondary objective is to validate one of the surveys we're using, and I'll touch upon that a little bit more now. To gather data, we're using a survey which can be seen on the left, as well as a semi-structured interview with some guiding questions, which you will see on the right. So yes, as you may realize, the study design is a mixed methods. The quantitative aspect is the surveys, and it's a 12-item Likert scale, and patients can select from strongly disagree to strongly agree and anything in between for all 12 questions. The qualitative aspect is a semi-structured interview. Again, we have guiding questions, but the interview can go into many places depending on how comfortable the patient is with sharing information. The study setting is in Southridge, which is the only place where we've gathered data so far, but we're looking to expand into other shelters as well. We're hoping to get 15 to 20 interviews as well as 40 to 50 surveys done, and these are numbers based on previous studies with the same population. Okay, here is a chart with a glimpse of our results so far. We've had 10 surveys completed and 2 interviews, and this chart shows the surveys. The higher the bar, the more likely the patient agreed with that question. So generally, patients are strongly agreeing with most questions, except questions 4, 5, and 8. And if you compare that to the questionnaire here, you'll see that patients are generally very happy with the care they've received at the clinics. Once we gather more data, we're hoping to analyze the survey data using descriptive analysis techniques, which includes calculating mean, medians, standard deviations, etc. And once we gather the interview data, we're hoping to do thematic analysis. Ultimately, we want to work with a statistician to do this, but we want to see if the interview answers can generate themes that were also found in the survey. And if they can, that will help validate the use of the survey for future projects. Okay, moving on. In conclusion, our objective is to understand the patient perspectives about the care they receive at the shelter health clinics, and we have to continue data collection to do this and then perform analysis of that data. And hopefully we can publish a peer-reviewed manuscript as our end goal. Some limitations of this project is that the care received during these clinics may differ vastly based on the time of the year, as COVID has affected us differently during different parts of the year. As well, the interviewers may be biased based on the results of these surveys. And we have many ethical considerations to consider as well, since we are working with a marginalized population. The interviews and surveys will all be done at the clinics, at the shelters themselves, to minimize the burden as well as the cost for the participants. They will also receive proper informed consent and have the opportunity to withdraw and ask questions at any time. And we have received approval from the Hamilton Integrated Research Ethics Board to complete this survey. And here are some references I used. All right, thank you for listening to my presentation. I hope you learned something and I hope you enjoyed the rest of the conference. Take care.